In addition to prerenal and postrenal causes of parenchymal failure, you can also have other conditions like a medication that damages the kidney even though the blood supply is great and even though there is no obstruction. You can also have a problem with blood supply or a problem with obstruction that is effectively resolved and does not damage the kidney. Therein is the heart of the difference between what we would call prerenal and postrenal oliguria and true acute kidney injury or true renal failure. In your acute kidney injury that results in damage to the actual kidneys, these are the patients that will go through an oliguric phase, a diuretic phase, a recovery phase. These are the ones that need a lot of intervention to get them through. If a patient has a prerenal oliguria or a postrenal oliguria and we can resolve that quickly, then damage may not have to occur to these kidneys. And while you may see some of the early symptoms of acute kidney injury, they're quickly resolved and the patient doesn't have to go through the phases and may not require, for example, dialysis. This slide is in here to address what hyperkalemia might look like. When potassium is in excess, and we use 3.5 to 5 as a normal range for potassium, when potassiums start climbing, and these are arbitrary increases, these problems may occur for patients well before they get to these big numbers here. But this is a P, QRS, and a T, and what you see is a tented or a peaked T wave. This T wave is bigger than it should be. Normally it would just go like that, okay? So that's a tented T wave. And then as the potassium continues to go up, you see some other things like widening of the QRS, and you see the PR interval starting to prolong. Then you can see the atria not responding at all, and then eventually the heart just stops being effectively conducted. This stuff is probably not as important for you to recognize as would be, peaked or tented T waves as a sign of hyperkalemia. All right, so what are we going to do for this patient who's got acute kidney injury? By the way, I'm using a different format for the rest of this presentation. This is Collaborate. I really like it. It makes clear, crisp slides. I wasn't able to use Collaborate prior to this because I was interchanging with the DVD, and I cannot pull a DVD through this program. So nursing interventions. Our goal, determine and correct any precipitating causes. Even if the patient is in full-blown intrarenal failure, whatever has caused that condition needs to be corrected. Yes, they're likely to go through all the phases, but that situation is going to be prolonged if we don't address the cause. We want to maintain homeostasis while the kidneys repair themselves, because really in acute kidney injury, you have to hope that the kidneys will repair themselves. And then we want to prevent and manage any complications that arise. Some nursing diagnoses to consider: your fluid volume excess, potential for electrolyte imbalances, altered nutrition, and risk for infection. Now, if you're in the diuretic phase, then you have to be concerned about fluid volume deficit. But in the oliguric phase of acute renal failure, not to be confused with prerenal oliguria, fluid volume excess is a problem. So in this phase, we need to restrict potassium. We're going to look at dietary restrictions. Remove all sources of potassium. Consider, does your patient have TPN going? That if their potassium is elevated and there's potassium in the TPN, that will have to come down. Anytime you take TPN away from a patient, you must hang D10. Otherwise, that patient's sugar is going to plummet. because their body has been used to a very simple form of sugar very readily available. So the dietary restrictions. That's not going to deal with the potassium problem that you're having that's an emergency. So in the emergency situation, we use calcium gluconate to stabilize the myocardium. It's not uncommon to give 10 mils of a 10% solution over 5 to 10 minutes. It's the first line of therapy if there's any EKG changes of hyperkalemia, and then we can repeat that dose if needed. There are things that we can do to shift potassium from the extracellular fluid to the intracellular fluid. So calcium gluconate stabilizes the myocardium. It makes it less responsive to the elevations in potassium. The next few things here shift potassium from the extracellular to the intracellular, and this is stuff you've already learned. It's just coming back. So we're going to give insulin, and when we give insulin, we want to make sure that there's a ready source of glucose. So we tend to give 50% dextrose with the insulin. 5 to 10 units of regular insulin is given IV push, followed by 50 mils of 50% IV dextrose. That's going to peak very quickly in 15 minutes maybe. We may need a maintenance dextrose infusion to prevent a delayed hypoglycemia, and we have to monitor the patient's blood sugar frequently. Again, it's not the sugar, it's not the dextrose that is facilitating the potassium shift. Rather, the insulin facilitates the potassium shift, and we give the dextrose to keep the insulin safe. There's another component here. The sodium bicarbonate may be given. Sodium bicarbonate, 1 to 2 amps. It will peak in 1 to 2 hours, variable response. But what you're doing with sodium bicarbonate is you're correcting acidosis. In patients who have acute kidney injury, metabolic waste products are not being eliminated. Metabolic waste products are acids. So metabolic acidosis is what goes with renal failure. So we give the bicarb to correct the acidosis. When acidosis being in excess of hydrogen ions, you give bicarb to buffer those, and it will force the potassium into cells. High hydrogen ion concentration, what the body tries to do with that is the body will shove the hydrogen ions into cells, and then in turn the potassium kicks out. So when we give the bicarbonate, that buffers that hydrogen and allows the potassium to go into the cells. So acidosis is associated with hyperkalemia. Correcting acidosis will assist in the correction of hyperkalemia. Keep in mind that these shifting things that we can do are temporary because as the body equilibrates, potassium is likely to move back out. Nebulized albuterol, I've not seen this used, but it certainly does work. Albuterol is a beta-2 agonist, and it will also cause potassium to go into the cell. The last 2 items on this list, K-exolate and dialysis, these actually produce elimination of potassium from the body. K-exolate is sodium polystyrene sulfonate. It's a cation exchange resin. It can be given either orally. It tastes awful. A lot of times you have to drop an NG tube just to get it down the patient, or it can be given as a enema. Enemas are extremely effective, and patients do drink this stuff. If you're hyperkalemic, we've got to get rid of that potassium. What it does is it will exchange the sodium in the K-exolate for the potassium, and then potassium is eliminated in the stool. So K-exolate does cause diarrhea. And then, of course, if the patient is hyperkalemic, that may be an indication for emergency dialysis to remove that potassium. Now, in the diuretic phase, the patient may become hypokalemic when they are eliminating 400 plus milliliters of urine an hour. The kidneys are not yet healed enough to hang on to things like they should. So you may actually have to replace potassium either orally or in an IV infusion. Up to 10 mils a day of dilute urine can be lost. It's going to have sodium and it's going to have potassium in it. All right, in hyponatremia, here's hyponatremia. Hyponatremia, what phase is the patient in? If they are in the oliguric phase, then the hyponatremia is likely going to be dilutional. It's not that they don't have enough sodium in their body, it's rather they have more water. So we will institute fluid restriction. We're going to institute fluid restriction anyway if they've got a fluid volume excess. Now, in the diuretic phase, the hyponatremia may actually be caused by the massive loss of this dilute urine that takes sodium out with it. So in that situation, you may be replacing blood volume with sodium solutions, normal saline, for example. Fluid management. Daily weights. If the patient is getting dialysis, they should always have a pre and a post-dialysis weight. That tells us how much water has been left, in addition to the dialysis nurse's report about how much they pulled off. For a patient who is in the oliguric phase of renal failure, the amount of the amount of fluids that a patient can have in is whatever you can measure, any kind of output that is measurable. So sometimes patients in renal failure actually do make urine. Or imagine that it's a surgical patient who's got an NG tube and there's output from the NG tube. Any output that you can measure plus 500 milliliters is what that patient is allowed to have in the next 24-hour period. Okay? The 500 mils represents what we call insensible losses. Losses from sweat, losses in our breathing. You know, there's moisture in our breathing. We want to make sure that we're monitoring the patient for either the fluid volume excess or the fluid volume deficit. The video actually did a decent job of telling you about what symptoms might be occurring in a fluid volume excess and in fluid volume deficit. Now, you do have to keep in mind that fluid volume excess and fluid volume deficit is not going to be happening in the same day. And, you know, the video didn't necessarily allow you to appreciate that there is some time that's going on between there. So, you know, in the oliguric phase, the patient may have fluid volume excess, and that excess may end up leaking into interstitial spaces in the lungs. It can cause problems with oxygenation. It can cause problems with the heart not being able to deal with the fluid load. Fluid volume excess that becomes symptomatic in and of itself may be a reason for dialysis. And then in the diuretic phase, the patient may have symptoms of fluid volume deficit. The key there is you notice that there's a large amount of urine being lost. Think about what that patient looks like who has fluid volume deficit. If we're not correcting the fluids, they're going to get tachycardic, they're going to get hypotensive, they're going to have those kinds of problems. All right, in nutrition, it's very important that we decrease catabolism. Kidney failure generally is a catabolic condition. It is associated with hypermetabolism and muscle wasting. Patients with acute kidney injury are very sick. So while we do not want to overload the body with protein, because urea nitrogen is a byproduct of protein metabolism, we want to make sure that the patient gets enough protein that they're not breaking down their own body protein. So in a patient who is not on dialysis, they're going to get 0.6 to 0.8 grams per kilogram per day. We do think of protein as being restricted in kidney failure. 40 grams per day is a pretty typical diet. We may have to supplement with the essential amino acids to prevent the body from breaking down body proteins. Now, if the patient is on dialysis, then we have a mechanism for getting rid of the byproduct of protein metabolism. And so they can get up to 2 grams per kilogram per day of protein. Dialysis or their GFR is returning. If the kidneys can deal with the byproduct of protein metabolism, then we want to make sure that they're getting enough protein to do that. Potassium, it's going to be restricted or supplemented depending on where they're at in the oliguric versus the diuretic phase. And sodium in the diet is going to depend on serum sodium and fluid volume levels. So goals. The goal for nutrition, decrease catabolism. Calories, we need at least 30 to 35 kilocalories per kilogram per day. That's at least. We need a lot of calories. For someone who weighs 70 kilos, I mean, just do the math. I weigh probably close to 70 kilos. 70 kilos, if I up to 35, 2,450 calories. Now, right now, if I were to eat that kind of food, I would be gaining weight. Not a good thing. But a person with kidney failure is sick. Your nutrition reference that is on the blackboard for you, Whitney, I like that reading. It does gives you a nice overview of the condition. I don't necessarily think you need to print it, but you should be able to read it right from your computer. If it comes up sideways, by the way, if you right-click, you should be able to rotate it clockwise, and you should be able to even enlarge it so that you can read it, comfortably. Those are excellent resources. I like that Whitney nutrition reference. You want to make sure that the patient has enough of their calories from carbohydrates and fats to prevent ketosis and to prevent gluconeogenesis. Remember those terms from diabetes. So that's probably 300 to 400 grams of carbs, 75 to 90 grams of carbohydrates. If the patient is not able to handle oral solutions, tube feeding oral solutions, I mean food. Tube feeding is preferred over total parenteral nutrition, although if the gut is not working, then we have to do TPN. In critically ill patients, sometimes the gut fails to work and we have to go with TPN. The gut is always preferred. There are reasons. Even if we can't give the total amount of calories that a patient needs and we have to supplement with TPN, if we can at all feed the gut, there's some definite advantages to the patient to do so. Infection control. Infection is the leading cause of death in acute kidney injury. It's often due to sepsis from contaminated IV lines. So strict aseptic technique is imperative. Also, we're going to avoid indwelling catheters. Yes, it would sure be nice to know how much urine is coming out, but we have other indicators, and the criteria for keeping catheters in is getting stricter and stricter. I would say that someone who's critically ill with acute kidney failure may very well receive a Foley catheter so that we can manage their output. But if we don't really need to know, and especially if they're not making urine, if they're not making urine, it would be totally not right to have a Foley catheter in. Dialysis or continuous renal replacement therapy is indicated to treat acute kidney failure in the following situations. So if the patient has volume overload that's compromising them, namely heart failure, pulmonary edema, their oxygen levels are low, we can't oxygenate them, that patient's going to need dialysis. Potassium greater than 6 is an indication. Metabolic acidosis with a bicarb of less than 15 is another indication. If the urea nitrogen is greater than 120 milligrams per deciliter, stop and think for a minute what normal urea nitrogen is. Okay, what's normal urea nitrogen? So when urea nitrogen is greater than 120, that's an indication, because urea nitrogen that's that high can produce uremic intoxication symptoms like encephalopathy, pericarditis, and bleeding. Clotting factors do not work well when there is this much metabolic waste product floating around in the bloodstream. So any signs of uremic intoxication, regardless of what the urea nitrogen level is another indication for dialysis. We will talk more about dialysis with chronic kidney failure, but hemodialysis is what's going to happen in acute kidney injury. It does require vascular access. The treatments will either be typically 3 to 5 hours a day or 3 to 5 hours every other day. Sometimes initially it's daily, and then hopefully they cut back to every other day, or hopefully kidney function returns. Peritoneal dialysis is not usually used in acute kidney injury. Continuous renal replacement therapy, this is much better tolerated in critically ill patients because it's continuous. If you think about the way your kidneys work for you and me, they're doing their job every day, 24 hours a day, gradually as needed, continuously. If I use hemodialysis, I'm hooking a patient up to a machine and I'm asking it to filter all the blood in 3 to 5 hours that it would normally do in 24 to 48 hours. So there's a lot more stress and pull on the system with hemodialysis. In continuous renal replacement therapy, the patient is hooked up to the same kind of blood vessel access, but it's continuous, and so it's much gentler. It's a much gentler process. The CADH is continuous arteriovenous. Here you have an arterial and a venous access, and it's the patient's blood pressure that's going to cause the filtrate to be produced. That's not probably the one we use the most. The CADHD, they use a large double lumen dialysis catheter. This is venous access. Yes, this is one we use a lot. It uses a dialysate delivery system. CVVH uses a pump to manage the rate of filtration. And then CVVHD, this is actually, CVVHD is the one we use the most. It uses a double lumen venous access catheter. The rate of filtration is much more reliable than using the patient's blood pressure. The difference, by the way, between CVVH and CVVHD is in B, there's a dialysate solution that is introduced across a membrane that allows for pulling of substances out, whereas CVVH is only dealing with volume excesses. Anyway, it's probably not important that you memorize these acronyms, okay? I don't think you're going to see that on the test. You do need to understand continuous renal replacement therapy, the notion that it's gentler for the patient than hemodialysis. It does require a high level of critical care. Normally, patients on CVVH are one-to-one with a nurse in the ICU. That nurse does not take care of another patient because they are hooked up continuously to a pump that, if there's a problem, a third of the patient's blood volume is cycling through this machine, and so it needs absolute ongoing observation and care. This is what a hemodialysis catheter might look like using the jugular, internal jugular approach. Subclavian can also be used. And then the femoral approach would be the least desirable. This is an example of what these temporary double lumen vascular access catheters look like. the blood is withdrawn continuously through one lumen and then replaced through the other. And you can see here, you know, the blood is drawn into, then it goes to the machine, and then it's kicked back out, but it's all in one vessel. Okay, that's it for the presentation on acute kidney injury. I know some of it was duplicated because you had some of it in the video, and then I went over the PowerPoints anyway, but hopefully that's better to hear it twice than not at all. Okay, the other thing I have for you that I'm willing to spend some time with right now is a couple of the case studies. You might want to pause and find those case studies. They are on the blackboard. One is the post-operative case study, and it deals with Mrs. Johnson. And then the other one is an acute renal failure case study that the patient is Mrs. Lee. So, you know, if you want to pause and find those case studies, and maybe you even want to work through them first, and then come back to this and hear what I have to say about them. Case studies are an excellent way for you to take information and make sense of it, but you really can't do that until you've dealt with the content. I'm not real big on giving answers to case studies because truly case studies work best when you do the work and not when I tell you what the case study looks like. Okay, I'm going to stop the recording for a minute and switch to the desktop so we can look at these case studies together. Okay, so here's the case study. Oh, I really want to do the other one first. Hang on, let me see if I can make that happen. There we go. Miss Jenny Lee is an Asian American woman. She's elderly. She is hospitalized for acute renal failure or acute kidney injury. She has osteoarthritis of her knee and shoulder. She's had cataract surgery. She's got osteoporosis. She takes ibuprofen. She's added Tylenol. She has back pain because of spinal compression. Control with her current analgesics. So, you know, lots of osteoarthritis kinds of situations. She only urinated once yesterday. It was just a little amount. Today she notes her feet are swollen, her skin is tight. It's been pretty hot outside, and she doesn't have air conditioning in her house. Now she knows she should drink more fluid, but she wasn't feeling very thirsty. She lives alone. She does have friends that look out for her. She's cooperative. She's intelligent. So these are her lab values. Her hemoglobin is 14. Her BUN is 30. Her creatinine is 1.8. She's got 8 white blood cells. She's got moderate CAF. So let's look first at which of these lab values are not normal. Well, the urea nitrogen is elevated, and it's elevated out of proportion to the creatinine. Remember that for every creatinine, you should have 10 to 15 urea nitrogens. So with a creatinine of 1.8, I would expect 18 to maybe 27. What I did is I took 18 and added another half. So if you took 1.8 and multiplied it by 10, you would get 18. 1.8 multiplied by 15 would give you 27, if my math is right. Her urea nitrogen is 30, so that's outside of that range. And plus, it's elevated. What is normal creatinine? Make sure you know what a normal creatinine is. And this is a 78-year-old lady. Creatinine comes from where? Okay, you got to think about that for a minute. Creatinine is the byproduct of muscle metabolism, not muscle breakdown, muscle metabolism. So your muscle metabolism is pretty constant throughout the day. The more muscle you have, the higher your creatinine can be. A 78-year-old woman probably isn't, you know, like a Hulk. Probably, you know, not a lot of muscle. She might be overweight. We don't know that. But I wouldn't expect that she would have a high percentage of her body being muscle. So 1.8 is first of all, it's out of the range. What is a normal creatinine? You guys need to know that. You've learned it. 1.8 is out of the range, so both the bun and the creatinine are elevated, and the bun is disproportionately elevated to the creatinine. The presence of the white cells and the casts is consistent with an interstitial nephropathy, which could be precipitated by the NSAID use and by the dehydration. So, you know, the NSAIDs that she's taking and the dehydration from the hot weather and not drinking enough, that combination looks like it has hurt her kidneys. The hemoglobin is fine. She has no other manifestations related to anemia. Anemia certainly does go with renal failure, more with chronic renal failure than with acute, because hemoglobin is managed by erythropoietin, which comes from the kidneys. You'll see more problem with that in chronic renal failure. She's also a little on the dehydrated side, and that might be elevating her hemoglobin somewhat. It asks what clinical manifestations correspond to the abnormal values. Well, she's got the oliguria, tight skin. Those findings correspond with the lab values that indicate low renal perfusion in this patient. So she's got a combination of an intrarenal, you know, likely with her history of taking the NSAIDs, that has likely damaged her kidney proper, and then the dehydration from the hot weather, not drinking, probably tipped her over the edge. So which risk factors of acute kidney failure are present? Well, we've talked about those. Her age, her NSAID use, the hot weather, no air conditioning, not drinking quite enough. Those are the ones that come to my mind. What nursing care needs to be implemented? Well, her renal failure was potentially preventable, and good education could prevent this from happening again. She has to stop the NSAIDs. That's going to be a bite because she's got osteoarthritic pain. She needs to learn that NSAIDs can precipitate renal failure, especially in older people. So she needs to talk to her doctor about adding any over-the-counter medications. Let's see. Older people are more prone to dehydration because their thirst senses are not as, yeah, no, it's still working. Her thirst senses are not as sensitive. So potential financial resources could be considered to assist her in a better living environment or getting air conditioning into her home. Now, if oliguria persists, she will need dialysis until her renal function is restored. At that point, she would need to learn about dialysis and self-management during her dialysis treatment. Okay, so that is the acute renal failure one. Let me find the other one. This is a post-op patient. This patient returns to the surgical floor at 11 in the morning. He's had extensive colon surgery. It's important to keep that in mind. NPO, NG tube, and she's got IV fluids, D5.5. So what's the tonicity of D5.5? Hypotonic, isotonic, hypertonic. It's going at 100 mils an hour. At 10 o'clock, the nurse notes that for 8 hours, urine output is 150, NG tube output is 800. So from 11 to 10 at night, from 11 a.m. to 10 at night. Fluids have been going in at 100, 850 at 150 of urines come out, and 800 of NG. These are her labs. She had bloods drawn at 9, and so, you know, as the nurse was tallying up all the I&O, she has these labs to look at. Hemoglobin's 11, a BUN is 40, sodium is 144, potassium is 4.8. So you call the physician, and you're giving him all this information, and he orders a 500 milliliter fluid bolus and wants to know what the bolus results are. So your priority problems for this patient. What are those problems? Priority problems for this patient based on what? All right, well, let's see. From 11, 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I have 11 hours. I have 100 an hour going in. And if I take an 8-hour urine output of 150, how much is that every hour? 150 divided by 8. Ooh, yuck. 18.75 mils. So what's the minimum? At what point do we say, okay, kidneys are adequately being perfused? That doesn't mean that the I&O is balanced, but at 30 mils an hour, we do think that kidneys are adequately perfused. So she's not even got 20 mils an hour coming out. And where is her volume? Well, it's all been third spaced into her gut because of this extensive colon surgery, and the inflammatory process has been initiated, and a lot of it's being sucked out of the NG tube. So if it's coming out of the NG tube, it is not a perfusing volume. So fluid volume deficit, her urine output is less than 30 mils. Her BUN is elevated. Okay, that should be a clue that the kidneys are not being well perfused. And in this situation, you know, hopefully it's because the kidneys are trying really hard to hang on to water, and they're hanging on to some BUN trying to hang on to water. Look at that sodium. What's a normal sodium level? Okay, you should know the answer. This is normal, however, it is on the high end of normal. Okay, 135 to 145 is normal. This is on the high end, and so it also suggests that there's not enough water. The potassium is not too high, but again, it is on the higher side. Okay, you also have to consider the insensible loss. And then, you know, think about the normal postoperative hormonal response that has to be considered. There's a normal stress response that happens postoperatively that causes the body really to try to hang on to stuff. So fluid volume deficit, risk for alteration in perfusion, acute kidney injury based on low urine output secondary to the fluid volume deficit. And this looks like it could very well be a pre-renal oliguria. Now, how do we know that? Well, if we give this 500 ml fluid bolus and nothing happens, well, we have to ask ourselves, has the kidney been deprived of perfusion for too long? It's also possible that 500 mils is not enough. First of all, the fluid's B5.5. I asked you to think and to tell me whether that was iso, hypo, or hypertonic. Well, in the bag, I'll grant you that it is hypertonic. However, for the patient, it becomes hypotonic because dextrose is metabolized and becomes free water. So when the body gets done doing the dextrose metabolism, that's sugar, you end up with water and half normal saline. Half normal saline is hypotonic. So, you know, that's not a bad replacement, but it certainly should make that sodium a little bit lower than it is, which makes that higher sodium even more suggestive of not enough volume. So you might need an additional 500 ml fluid bolus to get a result. So let's look at additional assessment findings to correlate with Mrs. Johnson. You should be looking at any signs of edema. Does she have puffiness? Does she have dependent edema that would be secondary to the stress hormone response from surgery, you know, the antidiuretic hormone and cortisol? You know, that puffiness, that dependent edema could be movement of the fluid from the intravascular spaces to the interstitial spaces, not because the intravascular space is too full, but rather because of the stress hormonal response, ADH and cortisol, leaving the intravascular space dry. Does the patient have tachycardia? What's the patient's blood pressure? If the patient is tachycardic and hypotensive, that would suggest fluid volume deficit in the vascular space. Now, if the patient has a true fluid volume excess, okay, so picture Mrs. Johnson. Let's say she does have some puffiness. She does have some dependent edema, but she also has tachycardia and hypotension. That is fluid volume excess in the tissues, fluid volume deficit in the vascular space. And if you want to take care of kidneys, you've got to have volume in the vascular space. So a true fluid volume excess would produce puffiness, but also you wouldn't have tachycardia. Blood pressure would be normal or high. And a true fluid volume deficit would produce poor skin turgor, tongue furrows, in addition to tachycardia, hypotension. And when I say true, what I mean by that is there was effort to pull from second and third spaces to accommodate the first space. Now, what additional labs would you like to have? Describe what the labs would imply about the patient's renal status. Well, for sure, I want to know what the creatinine level is. The creatinine level is going to be key in letting me know whether this has gone too far or whether this is potentially reversible by getting this patient fluids. She's still going to need some fluids. In all fairness, if these labs were drawn for this patient at 9 o'clock, the creatinine would have also been drawn. You'd also like to know what the hematocrit is. It tells you something about water levels. Urine sodium and urine-specific gravity. Urine sodium. If the kidneys are actively trying to hang on to volume because of a fluid volume deficit, then the urine sodium is going to be low. A low urine sodium for this lady would be a good thing. Then we can tank her up and her kidneys can be re-perfused. If, however, the urine sodium is high, then the kidney has already been damaged. So you're looking at a situation here. What is the expected outcome of the fluid bolus? Well, you would expect that urine output would improve. Sometimes if we give a couple of fluid boluses, the physician may order a small dose of Lasix to see if we can coerce or strongly suggest to the kidneys that they try to release some of its sodium and water with it. But you got to be sure that you fill the tank first. You don't want to give diuretics to someone whose tank is dry. If the kidneys have truly failed from an intrarenal perspective, the kidneys have truly failed, the diuretic won't help. So here we're looking at pre-renal oliguria versus intrarenal failure secondary to a prolonged fluid volume deficit. And I don't have enough information here to tell you which it is. The deciding factors would be what's the creatinine. If the creatinine is 4 and the BUN is 40, that's a ratio of 10, that's very suggestive of an intrarenal damage. If the urine sodium is high, that's very suggestive of damage to the kidney. And that in that scenario, you can expect this patient not to respond to the fluid bolus, not to respond if they give a little bit of diuretic, and to potentially require dialysis to go through the oliguric phase, hopefully the kidneys recover from the hit, and then a recovery phase, a diuretic phase and recovery phase. If I check the creatinine, and the creatinine is 1.2, 1.5, well, that's a kidney that's working. Okay, the bun in that situation is being actively reabsorbed to hang on to water. If the urine sodium is low, it's because the kidney is actively working. And if I can restore renal perfusion, that patient does not need to go through renal failure. Okay, that's 2 case studies. I know there are more on the blackboard for you. I would recommend that you work those. I will be available in some venue for any questions that you have. Thanks.